pour le panel.
Let's begin. Thank you for being here in this second panel. We will have the first presentation.
L'accès aux soins de santé par Teddy Goetz, qui est interne en psychiatrie à l'Université de Pennsylvanie et mène des recherches.
This is a single case on the research on inequalities in health. We'll also have Serge Buch. He works for trans people in community health on a federal level. We also have Nat Mulkey, Hendrix University graduate, also a fourth-year medical student in psychiatric medicine. Let us now begin the presentation.
Hello, everyone. We just had a shuffle of order and I was confused about that. So Sage, if you want to turn the video on too, I'll start sharing my screen. Okay, so my name is Teddy Goetz, and I am a psychiatry intern at the University of Pennsylvania in Philadelphia, United States. I use he, him preferentially, I'm also fine. Nat Mulkey is not able to be with us today, who's also a psychiatry intern in Vermont. And then my colleague Sage is also here, who's a community health worker. Both Sage and Nat use they, them pronouns. So we'll be trying to fill in for Nat as best we can today. So our talk is titled Sanctioned Gender, the medically unique case of referral letters for gender-affirming care. Passing to you, Sage. I know in advance.
Absolutely, thank you, Teddy. So currently the policy for letters is based on WPATH SOC 7, which came out in 2012 and is planning on getting updated at the end of this year. And mental health evaluations are still strongly emphasized in both evaluating gender dysphoria, which is basically asking the question, is somebody trans enough to have these surgeries, as well as evaluating what sort of preparedness somebody has for post-surgical care. So the referrals and the readiness letters vary depending on what the type of surgery somebody is having is. So there are in some insurances, letters required for hormone therapy, but most here in the US base themselves on informed consent. And that requires a qualified mental health professional or provider competent in the assessment of gender dysphoria. For most forms of top, chest, or breast surgery, 1 letter is required, and 2 are required for genital surgery, so from 2 different mental health providers. And in general, the letters that are required aren't standardized. So they're conducted by LCSWs, by therapists, by providers. And while the ideal number for top or chest surgeries is 1 to 2 visits, and for bottom surgeries is 2 to 4 visits. Sorry, I heard that it's hard to hear, so okay, a little bit closer to the mic. That number isn't standardized, and the questions that are asked aren't standardized, and it really depends based on what the provider has in terms of experience for not only writing these sorts of letters, but also what sort of experience and understanding they have of the trans community themselves. And so the questions vary everything from the choice or the need for surgery to the emotional and the practical readiness of somebody, to somebody's understanding of the surgery, what support they have, and questions about the life with or without the surgery. And that's really based on a cis assumption of, hey, this is what somebody's body is, and we're going to assume not necessarily that this surgery is good or not good for them, but we're going to assume that this surgery is going to be a big life-changing thing, regardless of how necessary it is for somebody's mental health. So there's a number of problems that that model brings up. There's a lot of barriers, and there is always going to be the financial burden of accessing mental health care, especially in places where somebody might have to drive a really, really long distance to find somebody who is well aware and competent in gender-affirming therapy. There's the time burden of accessing mental health assessments, which is paired with varying insurance requirements of some insurance companies having pretty intensive requirements of 1 year or longer with the same therapist in order to get 1 letter for top surgery, 2 letters for bottom surgery. And that gatekeeping sets up a lot of barriers to people actually being able to feel comfortable with their providers, with their therapists. And it ignores a lot of the autonomy of trans people and their experiences. And so those evaluations and those letters are a cited barrier across not only the in community and the trans community, but also throughout literature for accessing the gender-affirming treatment that they're seeking.
Okay, so in light of this, we prepared a few cases to compare really why this is a medically unique case. So thinking about, like, as a physician, there are very few cases in medicine where a patient is required to undergo psychiatric evaluation prior to accessing the procedure. And the standard for trans patients is quite distinct. So in order to highlight that here, we want to highlight some of the barriers, which I'm sure many of you are very familiar with already, but also thinking about why this is undue burden on the patient compared to other comparable procedures. So for the first case, we have a double incision mastectomy, which is often referred to as top surgery for an individual assigned female at birth. So for this case, we have a theoretical non-binary AFAB person named Kai, who's 25 years old, no other medical history, and wants to undergo top surgery, double incision mastectomy. So Kai, under the WPATH guidelines, would need 1 mental health letter, which would evaluate whether or not, oftentimes, providers will kind of go through the gender history. Like, have you felt like you weren't your gender since you were 3? Did you like different toys than you were expected to? Things like that, to try to prove that you are the gender you say you are and therefore deserve the care that you are seeking. And then that evaluator oftentimes must be someone with an MD, a PhD, or a PsyD, which most therapists are not, and that can be more expensive and harder to find depending on your geographic location, and must have a recurrent long-term relationship and seen recently, and insurance oftentimes does not cover the cost of that evaluation or those many visit evaluations. And additionally, for this patient, let's say that Kai is not on testosterone therapy. Even though WPATH guidelines do not stipulate that someone must be on testosterone therapy prior to getting top surgery, many insurance companies will require that, which causes another burden, because not only is that more time before someone gets their medically necessary care, but also someone might not want testosterone therapy in order to reach their gender goals. And if they have to decide between a surgery they really need, but the hormonal therapy that they don't want, that is really medically unprecedented otherwise. For comparison here, if we have a theoretical cisgender woman named Kara, who's 26 years old and has same medical history as Kai, but is seeking a breast reduction surgery, no psychological evaluation is needed, and there is informed consent regarding future ability to lactate and scarring and potential other complications. And that process is not gate kept the same way. Moving to our second case, which is a vaginoplasty, we have Crystal, who's a 26-year-old trans woman, no other medical history, seeking to undergo a gender-affirming vaginoplasty surgery. So Crystal would need 2 different mental health letters instead of 1. Again, same things for it, and insurance will rarely pay for one of the letters, meaning the visits needed for that, let alone two, and those both have to be recent and with different providers. Crystal will also need an endocrinology letter and to be on hormones for at least 1 year. And then some insurance companies additionally require more time with that or additional concerns. Barriers for Crystal, though, are geographic. Let's say that if Crystal lives in Utah, there are not providers around who are able to provide that. And Medicaid, does none of the covered therapists who are accessible by public transport could have written those letters before. So thinking about how it's like not only are these letters an emotional barrier and a financial barrier, but in a time sink, but also there are other geographic problems with this and insurance barriers. Again, this is a US centric talk because insurance barriers obviously are quite different, and provider access and the whole process differ very much internationally. So giving a comparison for that, if there were a cisgender woman who, let's say, is a similar age and seeking to undergo a liver transplant, the psychological evaluation for that case, that's one of the few procedures that does actually require a psychiatric evaluation, psychological evaluation. But that evaluation is a one-time visit covered by insurance, gauging psychosocial stability and ability to comply with the medical treatment post-op, the anti-rejection medications, things like that, which is a very complex undertaking. But organ transplant requires that evaluation, which is much less than someone who's getting gender-affirming care. Patient will also need to stop smoking if applicable, and the letter would also assess smoking or social support, which, because it's a lot of post-op care that would be needed for that patient. So you can see that there's a very strong difference between these two surgeries, even though both theoretically, require a psychiatric evaluation or psychological evaluation. The barrier on trans patients is much greater. For our third case, we've got a phalloplasty. So let's say Oliver is a 33-year-old trans man, no other medical history, who's seeking to undergo phalloplasty surgery. Oliver, like Crystal, will need 2 mental health letters, same barriers to that, and also the endocrinology letter and 1+ years on hormones, even though hormones do not impact the outcomes after phalloplasty, and barriers to getting those letters. Let's think about in this case, and again, each of these cases is just one case. We're just trying to highlight a few of the different additional barriers to the ones that might show up on paper when we're thinking about these evaluations. But if, let's say, Oliver is not someone who's externally legible as a man, which is often referred to as not passing, which is appropriation of racial language. So I should not do that, but hence the quotes. But if Oliver is a feminine presenting trans man who is a fat bodied individual who has large hips, who cannot grow facial hair genetically, a therapist or a psychologist or a psychiatrist is less likely to deem him suitably masculine enough, male enough, in order to warrant that surgery, which could be a major barrier. And the additional barrier for this possible patient, as we've discussed in the last session this morning and in the poster that I put together with a few of my colleagues, Justin Hoffman, Elijah Castle, and Ian Rosdell, who was in the previous talk, surgeons are oftentimes not willing to operate at all on someone with a higher BMI, which there's no actual medical literature for that, but it could be the surgeon, it could be kind of the idea of aesthetic outcomes, which again, we have to check our own fat phobia within the medical industry. And additionally, facilities might not be willing, or anesthesia might not be willing. However, here we will contrast that with someone who was seeking bariatric surgery, who has the same BMI, who would be encouraged to get surgery and able to undergo that surgery. And the psychiatric evaluation in that case, sort of the organ transplant, bariatric surgery being the two most common other examples of this, is similar to the organ transplant, with just a one-time evaluation, assessing understanding of the risks and the intensive recovery and the long-term need to take medication, in this case supplements. And that is covered by insurance and oftentimes can be done by an LCSW or NP, which is easier to find oftentimes than a doctoral level psychiatric or psychological practitioner. However, I wanted to note here, the complication rates for weight loss surgery are so much higher than they are for phalloplasty, which again, we think about the barriers to, does someone understand the informed consent process? The informed consent process is much quicker and oftentimes glosses over the real long-term potentially dire side effects of weight loss surgery, when instead the much more intensive process is used to prevent trans individuals and non-binary individuals and or gender expansive, gender diverse individuals from accessing medically necessary treatment. So seeing these three cases, we hope you can appreciate the medical uniqueness of the way that trans patients and non-binary patients and or gender diverse, gender expansive patients are treated in the case of trying to access gender-affirming surgery. And so therefore, we wanted to think about what is a better way than the current system, which is highly inadequate and sets up a lot of barriers to reaching care. So we will be proposing here, reviewing recently suggested better models and proposing our own. Back to you, Sage.
Thank you.
One of the recent proposed models was...
You just have 2 minutes left.
Thank you. One of the recent proposed models that was put out was by Mount Sinai, and they analyzed, hey, what are the requirements that we're having our patients use when we're coming in, and how can we minimize those barriers to patients? And that is something that they have sent into WPATH for SOCH 6, and they compared, hey, what are the percentage of patients that are able to access vaginoplasty under our guidelines versus WPATH? And they found that 45% were eligible under their guidelines, while only 15% would be eligible under WPATH. So they broke those down into what are the medical requirements, the mental health, and the social work requirements. So under their proposed guidelines, they remove the requirement of the 2-letter approach, as well as eliminate the vagueness of the well-controlled mental health symptoms. So they list those now as no self-harm, no suicide attempts, and no psychiatric hospitalization in the last 6 months, which has made that easier for providers to have a sort of cut and dry guidelines on what that might mean by well-controlled symptoms. Unfortunately, they also changed the mental health screen so that it has to be done by a doctoral level provider, which eliminates a lot of the options, especially for low-income individuals, for those letters. And it still requires that external mental health evaluation outside of everything that's already being undergone for their surgery.
So an alternative option with this, aware of our time here, would be trying to do informed consent, which would discuss the risks and benefits as done for other procedures, because these are medically necessary procedures, just like other surgeries that one would get. And this would be without requirement of specific mental health evaluation, but would of course support treatment when necessary and recognize autonomy. So the challenges, however, of an informed consent model purely are that it's not uniform, often based on WPATH, which insurance companies just generally misinterpret to their advantage to try to prevent having care covered. And it's for youth specifically, the language generally around assent, not consent. And the approach would have to be tailored to the stage of development, knowing that capacity for minors can be more complicated. So for us, we were thinking, after having all of these different reviews, that having informed consent would be the best option, but having a letter requirement based on the follow-up care required for the procedure, as is required for other procedures, thinking back to the cases that we presented. So for top surgery, similar in follow-up care to a breast reduction, there should be no psychiatric evaluation needed. For bottom surgery, which does have much more intensive follow-up care and a more intensive surgical process and more risks, any mental health provider should be able to provide a letter. It should be a one-time meeting covered by insurance, documenting the risk-benefit, follow-up treatment plan, and adequate social supports, which would remove many barriers to that individual who's attempting to get care, getting the care that they need. So sorry for the hurriedness at the end. My name is Teddy Goetz. You can access me via email, same for Sage, and our colleague Nat is more on Twitter than their email, but they are accessible as well and ready to chat with you about this. Thank you.
Merci beaucoup pour cette présentation. Maintenant,
Thank you very much for your presentation. We are now going to introduce the next presentation about how to provide support and advocate for trans people in transition and emergency situations.
Alors, pas rallumer ma caméra, parce que c'est normal.
Hello, I don't know why I cannot
Si vous
turn my
pouvez, ça serait
camera
quand même mieux qu'on puisse voir
on.
mon visage pour la... Je veux dire, voilà. Je n'ai pas de PowerPoint.
It would
mais déjà,
be
je vous souhaite un bon à
better
tous, à
for
toutes,
me
pour cette présentation.
if you can do it for me. I do not have a PowerPoint presentation.
Ok. Ben, je vous remercie
Oh,
tous
okay,
d'être venus
better.
assister à cette
That's better.
présentation.
So you turn my camera on
Ferrero,
for
je
me.
suis,
I want to thank you all for being here. I'll ask you to please space yourself when speaking. We have translation both into English and into Spanish. All right, I represent the Transat Association. Is an association founded in Marseille in 2018. And we work in Marseille, a city in the south of France. And we work in the blue coast, the southern region of France, when there is a large rural area. Our target population is a mixed population from a sociological standpoint. Marseille is a very poor city, some of the most underserved areas in Europe, but at the same time, we have some of the most privileged areas. So as you can see, we have quite a varied social mix. We have an audience of a very socio-economic characteristics. I would like to speak about the status in France for healthcare. At our Transact Association, we provide awareness and training programs for clinicians. So not only do we support people, but at the same time, we provide training for medical doctors, social workers, and the public in general. And we try to do is to raise public awareness and provide everyone the necessary tools to understand and address transphobia. I would like to begin by describing the French legal framework when it comes to healthcare provision for the trans community. So the problem to access healthcare in France has always been difficult from a legal standpoint. A few years ago, there was a lot of awareness programs in terms of this difficulty of access, but the main problems is the legal framework, the public health code, or the legislation in France. When it comes to healthcare, we should say that everyone should have a free choice as of their healthcare providers. This is quite important. And we also need to mention that, as was mentioned in the presentation before me, there is a requirement for a mental health certificate. French law and the criminal code establish that people should not discriminate in their access to healthcare. So we should not ask more of a population, for example, because they are minors. Of course, they cannot be mistreated in the sense that it should not make a difference the race, or ethnicity, or social status of the person. The public service should be equal for all, and access to health should be equal for all. Technically, a trans person in France should have free access to healthcare, whether that is therapy, whether it is surgery, whether it is hair removal. They should have the right to go to any healthcare professional, and that is the right set forth by the law. Hormone therapy, for example, hormone therapy can be prescribed in France. It could be prescribed by a neurologist, gynecologist, or GP. And general practitioners could prescribe hormone therapy for cisgender persons as well. For example, the pill is a way of hormone therapy. In fact, a person who would like to begin a hormone therapy in France should first visit a general practitioner and request a prescription. Now, historically, the law sometimes not respected. These rights are not respected. In France, trans healthcare sort of became an issue in the 1980s, 1990s, where the new Trans Healthcare Association was established, and actually this association was recently dissolved. I'm sorry about that. So this French Association for Trans Healthcare is a medical association that would bring together physicians who would follow a very rigid protocol. That protocol is somewhat of an earlier version, which was very strict and required tests for the person to sort of be reaffirmed as a trans person, and very rigid from a regulatory standpoint. So these physicians who founded the association required, for example, a trans female to bring or to meet certain requirements and undergo certain treatment with professional doctors. For example, they would be required this person not to be HIV positive, they couldn't be depressed, they had to pass a mental health evaluation that would take many years, and after that they would set up a meeting among many doctors who would evaluate and approve or not that person. And the physicians that had founded this association would be open to transition, and they considered that the trans identity was a disease, was an illness that was incurable. It was a mental health problem to them, and there's evidence of on the logic of these people, and it's been published, Dr. Cuvier, and you could very easily find the publications of these doctors where they state that trans identity was a mental health disorder and the only option to access medical transition was if that person had attempted suicide, and there wasn't much to be done. Thankfully, we have evolved, and even in that association, there were some doctors who did not agree with that stand. And what is also important to mention that in France, it is not necessary to undergo these consultations. It is not mandatory, although they are in place. The law allows us to select any medical provider. The thing is that these protocol consultations became the norm, and since they became the norm, medical practitioners or GPs continue referring people to those physicians, and they continue to be subjected to those consultations. And it it takes many years, and it is quite dramatic. So it is true that discrimination is still prevalent and the requirement of the mental health consultation is discriminatory. And for example, gynecologists or GPs will do so. And from a legal standpoint, this is the situation in Marseille, and I undertook, I carried out a survey on the ground to try to address this situation. That, of course, it is a very complex situation. There is a third stakeholder, the private sector, and physicians from the public hospital are part of this association, this effect. And then we have to think of a third actor, which is the health insurance.
In France, we have a public health system, and everyone can actually request a refund, and not all medical acts are refunded. A cosmetic surgery is not, but at least there is a large number of medical acts that can be refunded. This is connected to medical transition, which you must pay, and there is a regulatory framework that has to do with long-term access. This actually requests the Social Security Service, and then there is the full payment of medical transitions. Actually, we'll consider that we can also certify that this happens at different levels. First of all, with physicians, and also from a medical coverage perspective, there are some refund conditions that will be very different in different places, depending on the patient's medical coverage or medical insurance. You have 5 minutes. Thank you. Okay. Now I will give you a further example. We'll be talking about Marseille now. From a national perspective, things have evolved greatly, and at Transat, we are lucky to be part of the medical association that replaced SOFEC when it was called Transgender, which I will be addressing later on. It is our responsibility to defend ourselves. There are physicians coming from all over France that implement protocols, and we need to change the mindset. There were local physicians, and there was local implementation of the protocols. There was a health center where a GP prescribes medications without any kind of psychiatric certification. These physicians work normally, but in some cases, some cases were rejected because there were cases of depression, pathologies, mental disorders as well, and people with disabilities. So we have trained these physicians and other physicians. We are trying to raise the awareness of physicians, because tomorrow's medical care needs to include every specialty. For instance, we have a great surgeon, but I will stop here because it's really interesting. This surgeon has been threatened by other physicians. There is a GP as well we work with, and this physician worked at the European hospital, and she had to leave because she wouldn't be allowed to see transgender people, because they told her that she didn't respect the protocols. This is a protocol for social security purposes, the Accompagner protocol. But as she did not follow the recommendation and she does not request this mental health certificate, the Social Security threatened that they would stop paying her. They said they were going to penalize her and that she wouldn't be able to perform any surgeries any longer. So the surgeon started to request psychiatric evaluations and also worked with other physicians in a multidisciplinary way. So the blocking is legal in nature. Even if physicians know about this, many times they cannot really exercise their profession as they would like to. They cannot see patients without the mental health certificate because the system doesn't allow them to. So nowadays we need to think about medical care that respects people and also respects the physicians that really want to work. We need to protect both parties, and this doesn't exist anymore. Common law is great, but it doesn't show things clearly. Therefore, we have some refund issues in the social security sphere. For instance, there are many people that have to present claims because they need to pay for their own social security benefits. Also, regarding a specific procedure, if someone requires a specific procedure, a gender affirmation procedure, let's say that surgeons do not perform the surgery. They base their work on the Goetz protocol. And they don't request this protocol to cisgender people, but they do so with trans people. So the social security people do not know what to do because they have different types of requests. What is this Goetz protocol? Do they need psychiatric certifications or not? Maybe requests are rejected. Maybe they say, why are you sending me a request if you cannot perform the surgery? So patients are not really seen. Trans people are not considered in the law. At Transat and through Transat, we see the will of new laissez-faire practitioners who would like to just eliminate this effect and the Goetz protocol. Okay, internationally, the standard is for psychiatric evaluations to be optional. There is no obligatory medical evaluation. So in France, we need to update this medical care protocol, and also physicians and associations need to update themselves, because in Transat there are physicians and associations that need to update the protocol. This is a historical moment for healthcare in France. We really would like to help contribute to good practices and a general message for everyone. Thank you very much for your questions. You can go online and have a look at our Transat website, where we explain transgender, what transgender people are. Of course, you're welcome to ask me questions in the Q&A session. Thank you very much. Thank you very much for this presentation. Now let us go on to let's see what happens in with Charles Davids and Washington Silk.
Good morning, everyone. I just want to make sure that my co-presenter is here. Yes, okay, I see them getting connected. So thank you, everyone. So today, Wash and I are going to be talking about a paper that we wrote that's titled, "We're All in an Abusive Relationship with the Healthcare System, Collective Memories of Transgender Healthcare." So Wash and I are coming to you from Canada, specifically in the Waterloo region, which is just about an hour and a half away from Toronto, just to give people some context. So my name is Charlie and I am a PhD candidate. So I come from a researcher background. Wash is a healthcare provider. And I'm going to turn it over to them so they can introduce themselves and start us off with a land acknowledgement.
Everyone, my name is Washington Silk. I am a therapist in Waterloo region. We wanted to include a land acknowledgement. So where we are is the traditional territory of the Attawandaron, also known as the Neutral, the Anishinaabe, and the Haudenosaunee people. Where we are, originally 950,000 acres were set aside for the First Nations folks on the Haldimand track, but today only less than 5% remain in the possessions of the Six Nations. We're doing a lot of land acknowledgement as a first step in reconciliation. It acknowledges both the original people of our land, its ongoing stewards, and the broken treaty relationships that still affect us today. We want to acknowledge that colonization is an ongoing process where systemic and institutional powers have and continue to oppress and marginalize Indigenous people. Colonization has also deeply influenced the way non-Indigenous people understand historical and current relationships, often obscuring harm and justifying ongoing harm. There is no well-being without reconciliation and accountability. We are guests on this land and we are committed to change.
And can you speak more slowly for the interpreter?
Yes, thank you.
Thank you.
So in Ontario, in 2016, there was a significant change around how trans healthcare could be accessed. So it was decentralized and trans people were able to go to their family physicians for both general and trans-related healthcare. So this includes hormone therapy, referrals for surgery, and any other care associated with this. However, when the switch happened, healthcare providers did not have the education needed to provide this, as often it's not part of the curriculum. So many physicians either couldn't provide this care, or if they did, really relied on heavily on WPATH standards. So they would often require a letter, which isn't required. There's a lot of consent-based care that is also administered within the province. So we want to acknowledge that when this process happened, it wasn't done in a way that was affirming and supportive to trans people. And so it often kind of infringed on trans people's autonomy and was stigmatizing, patronizing, and alienating. So we know that many students are not provided training. I've had the ability to train medical students in the province as a MSW, RSW, which is very interesting. And they don't really have access to it as part of the regular curriculum, and they have to go out of the way to find it. And many times they just stumble upon it. And another significant barrier that happens is there's lack of clarity around who should be providing this care. Should it be an endocrinologist? Should it be the family physician? Should it be a specialist? Should it be a psychiatrist? Should it be a pediatrician? So in this way, people are often shuffled around the healthcare system without any consistent support.
I'm just interjecting here with a request from the interpreters. They're asking you to slow down quite a bit. They can't interpret.
Okay. I'm going to do the best that I can. My apologies. Okay. So these gaps in our healthcare system have resulted in scholars and advocates needing to argue for more agency and autonomy over our healthcare. The desire for greater autonomy occurs in many areas of transition. So this includes how people label themselves, whether people need to present a certain way in order for a doctor to agree to render or provide gender-affirming care. We're arguing that trans people independently become aware, validate, and create our trans identities and only access medical care to realize their transition goals. So the requirement of a referral letter, both for HRT or surgery, we're arguing is an infringement on the patient's autonomy.
So the study that we conducted utilized something called collective memory work. And so this is a methodology rooted in feminist perspectives, and it allows the researcher and the participants to really center people's lived experiences and look at how these lived experiences can connect to some larger systemic factors. So within this study, we asked our participants to create, to write down a memory that included both a negative experience with the healthcare system, as well as a positive experience with the healthcare system. They wrote these memories in third person, and they were asked to provide as much detail as possible. And in order to, one of the reasons to do this is so people can take their memories and talk about them in more of an abstract way, but still be centered in people's lived experiences. So overall, we had 6 participants, and their ages were from 17 to 30. 5 participants were white, and we had 1 South Asian participant. Overall, it was a 3-hour focus group where we had a facilitator who was also a participant who directed the participants to explore the content of these memories through the following prompts. So, what is this story about, and what does it mean? What is the author's perspective on what it means to be trans? And what does it mean to experience healthcare in this story? So while the participants engaged in this process of analyzing the stories, they came to collective agreements about the meaning of the stories, the intentions of the authors, and the intentions of the other actors or people within these stories. Next, the facilitator asked the participants, how do these groups of stories of the healthcare inform our understandings of trans experiences? And what are the implications of these messages, both individually and structurally? Okay. So we had a few results, and I'm going to center our results in quotations from our participants. So the words on the screen that are italicized or within a different font are quotes from our participants. So the main overarching theme or analogy or metaphor that our participants grounded a lot of their experiences in was this idea that interacting with the healthcare system was like being in a toxic relationship. And so the participants first started talking about this within this following quote. So Dahlia, while explaining what the healthcare system is like, said, It's almost like you're walking into you're in an abusive relationship with someone and you do not know whether it's going to be bad or not. But whether you still want to, you're just stuck there. It's like being stuck in an abusive relationship. Ash responds, unfortunately, we're all in an abusive relationship with the healthcare system and we can't escape it until the day we die. And it says, and you're just waiting, and you're just like hoping for the best. Like, is the healthcare system in a good mood today? Did I say the right thing? And Sarah chimes in, but actually though, this is a very good analogy sometimes. And so within this analogy, there were three main components that I want to focus on. One is the power that the healthcare system has on trans people, the lack of accountability in the care that we receive, and then the emotional toll that these interactions can have on us.
You have 5 minutes left.
Okay. So the first one is looking at this unrecognized power. And so this primarily centered in this process of gatekeeping, which our first presenters today did a really good job of explaining. And so within our study, this gatekeeping was most salient between two participants' stories. So the first story I'm going to talk about is Knox. So Knox focused a lot of the negative memory or the negative story on experiences they had interacting with a gender clinic as a youth. And this gender clinic required numerous sessions to prove, where Knox had to prove their transness. So is this hand raised for me?
You can continue.
Okay. So they had to prove their transness, and the gender clinic eventually started postponing their appointments until they eventually aged out of the clinic, because the clinic was only able to help youth. So once they became a certain age, the clinic could no longer help them. And then conversely, Knox centered to the positive experience with being able to access an endocrinologist as an adult and have someone answer all of the questions that they had. And the other story was from Ash, who was unable to access healthcare in the timeline that they wanted in Canada. But since they were an international student in Canada, they went to the States, were able to make a same-day appointment with an endocrinologist who was practicing informed consent and was able to walk out of the appointment with a prescription. And when talking about these two stories together, the participant said, I have to word it evasive, like double underlined at this point. It's like, what is this question of who gets to define your identity in your own care? In Ash's positive story, it was very much they got to define what their transition was and what their own care meant for them. In Knox's case, it very much feels like the doctor is trying to say, well, we have power over what your transition is going to look like, whether you are trans enough. And the fact that I need to say this is ridiculous. And another way that this came out was this idea that trans people, are bearing the burden of advocating for ourselves while wrestling for control within these healthcare situations. And so one way that this, one memory where this was salient was in Sarah's case. So when Sarah was accessing a clinic, she was able to list her name and her pronouns on her medical chart. However, both the nurse and the doctor used her wrong name. Sarah tried to correct the doctor, but she was told she should have informed the intake receptionist so this error would not occur. And the doctor failed to apologize when Sarah pointed out two her names and her pronouns highlighted on her chart. So the implications of this memory were highlighted by the participants as the doctor's authority to shift responsibility and thus blame from the doctor or patient. And so I'm just going to talk about the second half of this quote just for time. And so Dahlia says, this is the typical attitudes doctors have, never their fault for anything. It's just like, yeah, intake or receptionist or somebody else must have. It shouldn't be up to me to say sorry. Somebody else's job is to say sorry or apologize to you. It's almost like, yeah, they're shifting the blame.
And we're getting at 15 minutes.
Sorry?
It's 15 minutes now, so if you have something to conclude.
Okay. Let me, I'm just going to go to my summary, if that's okay. So yeah. Some of these implications and future directions, a lot of what the research in Ontario and our research is showing is that trans people can't access healthcare because the healthcare doesn't and wasn't designed to suit us. And so one of the ways in which we're trying to move forward is by looking at where some of these barriers are within the system and trying to advocate specifically for those. So this study was part of a larger project in which we wanted to create medical conferences that were run by trans people for medical providers. So we were able to give them the information that they needed to feel competent and have the capacity in order to treat us better. So I will end it there just for the sake of time, but I did upload our slides online, and here are our emails if you do want to contact us. Thank you.
Merci pour votre présentation. On va passer à la dernière pour ce panel qui est pas de...
For your presentation. We are going to move then to the next panel.
Pao, je pense que vous pouvez y aller.
May begin.
Buenos días, buenas tardes, buenas noches.
Good morning, good afternoon, or good evening. We are part of the Trans Assembly for Comprehensive Healthcare, and we have this presentation that says the title of our presentation is "With no healthcare, there is no pride." We are located in Buenos Aires, Argentina. Our healthcare system in Argentina is a three-tier system, state or public system, union welfare, and the private sector that you might be able to afford or not individually. We have a gender identity law that was passed in 2012, making sure that any surgical or any type of intervention, hormone therapy, or any other should be available to all people without the need to fulfill any paperwork, administrative, judiciary processes, without need to double check identity cards or prove the willingness for surgical procedures or any sort of proof of any kind in the framework of other won battles in terms of equal rights, for example, equal marriage, that takes away any sort of requirement or any sort of intervention. We have a mental health law depathologizing trans identity and actually banning trans identities, among others. The gender identity law also warranties the amendment of identity cards for minors with the consent of their family, or a judge, and it also allows, with certain authorization, surgical interventions for children of 16 and 18 years of age. We also have the possibility to make sure that the name that we have selected should be respected in any sort of occasion where our name has to be called out in public. And we guarantee the right of boys, girls, and teenagers to use their name in any sort of record and identity, for example, schools, healthcare clinic, or any public spaces. Trans people can use their chosen name without a need to change any of their personal records. In 2018, our Ministry of Public Health was closed by a neoliberal government, and it was changed into a secretariat, and there were movements and protests across the country for free access to health with no cuts. In 2016, since there was a shortage of hormone therapy and difficulty to access healthcare, we put together this group, this assembly, and we protested in many occasions in front of the Ministry of Public Health and in other public spaces in Buenos Aires to call for the access to our rights. We brought together over 150 people. We can see some pictures on screen of these protests in the streets. And in 2020, in the midst of the pandemic, the COVID-19 pandemic, some of our activities moved online, although we continue working on the ground, especially in situations of extreme vulnerability. In 2020, our country discussed a law for labor access law for trans and non-binary people, and we conducted different workshops for political training to support this process together with other organizations in our country, and thankfully a labor access law was passed for trans people in private and public environments. We also work together with other organizations like Recursero Trans. We encourage you to visit the site. Recursero is a digital space that collects and gathers information about transition health and further information, cultural information, different type of processes, paperwork, things that you need to do, for example, to change your identity card, access to healthcare, access to education, and so on. The trans community uploads different information about the status of healthcare availability and different services provided. So there's really a two-way street where we can not only gather information, but we can also contribute information so we can share it with our entire community. We have an agenda of different processes in Congress, access to healthcare, access to hormone therapy and medical treatment, different requests. There's a decree that's been recently passed that allows for an X to be selected as the gender mark. We continue to call for an open field in our identity card so we can choose other gender identities besides F, M, or X. We understand that those three categories do not represent the entire non-binary spectrum. There is also a quota for employment that's not completely enforced across the country. We requested for a census to be conducted we want further participation of trans people in public policy and in justice. We demand there is a stop in the homicides of trans people. And we also have different publications that you can find on social media. It's been produced by this group, by this association. As you can see on screen, this is one of the papers. And we also have a clip to show you where other members of our organization will let you know what the healthcare access situation in our country is and what are our demands. Thank you.
No sé si tienen el video.
Can you see that clip? I'm not sure if I'm sharing it, or could you share that clip? Health. Without health, there's no pride. The meeting was put together when there was a shortage of hormones for hormone therapy, and comprehensive healthcare means physical, mental, psychological health, and any sort of emergency that might put your life at risk. For example, legal processes, or having our basic needs covered as housing, or any other situation that might put your mental health at risk. It is also contemplated under the umbrella of health and healthcare. So anything really pertaining our life, or anything that means being a trans person in a cis-sexist system where our basic needs are limited, should be considered under the definition of health for our group. We understand health not as the presence or absence of illnesses or disease, but rather the combination of different accesses or lack thereof of rights that will lead to better or worse conditions of life. So this combination of rights that is crystallized in our health, or it's materialized in our health, has to do not just with the physical, anatomical, or psychosocial aspect, but it is also affected actually by other variables like access to work, housing, education, or healthcare devices in particular. But as we have discussed before, access, for example, to our political engagement, decision making in politics that is undertaken by the state by implementing or not implementing public policies, discussions that we are invited or not to participate in, among other variables. So as I said before, we consider the comprehensive health will always be conditioned by This way that we are able or not to develop our life in the broader sense. This, of course, has a close and an obvious association to the very short expectancy of life for the transvestite and non-binary population in Latin America in general, but in Argentina in particular. And even though we have built a legal framework and a regulatory framework to improve the quality of life of our communities, we still know that there are many public policies that are to be approved, and there are many other actions the state could take and the civil society could adopt for our lives to be more enjoyable and free of violence and free of structural hatred towards the transvestite, trans, and non-binary community.
Hello, I'm Eva. I'm a transgender person. I would like to share my experience. I have been discharged from a prepaid health association. I had a scheduled mastectomy. I had all the necessary documents that they requested. I needed to, the prepaid association needed to respond in 3 days, and this I placed a claim. I placed many calls as well in order to ask people why the health association was not accepting my surgery, and they kept saying that it was in the process of being medically audited. On the day of the surgery, it was still in process. In the midst of all that, I was diagnosed with cancer, which also required a surgical procedure. And this procedure was indeed accepted. So this shows that it's not a red tape issue of the health institution in itself, but rather they do not want to implement the gender identity law that supports me in my transition process. In the transition process I need, and this can take place in the public or the private system. So this is still in process nowadays. I wanted to share my experience with a prepaid health association. When I started my hormonal treatment, I made an appointment with an endocrinologist, and in the appointment she told me that she didn't see, and she said this literally, she didn't treat gender dysphoria cases, and she transferred me to the Durand Hospital, a public hospital. And this goes against my health rights. So it was very serious. I did have the experience at the room at La Matanza. This was a lovely experience. It was a great project, but now it has been closed down. It was a comprehensive health project. There I started my hormonal treatment. I had the necessary tests. I had a psychologist or therapist I could talk to. I think it's necessary for comprehensive health to be accessible to everyone. It's a right. And as transvestites, trans people and non-binary people, we need to be able to have these different health options. In my current situation, and as I am non-binary, when I go to a friendly clinic, or when it focuses, it has been specially designed for trans people, and there are experts in trans health, that's already amazing. So I have been socialized as a woman, and they understand that actually but actually my pronouns are neutral. Nobody asks about my identity. They assume how they should call me. So the state or someone else is deciding my identity for me, and they are imposing this identity. Or when it comes to having gender reaffirmation surgery, I want to have a mastectomy. And they call this masculinization. So it's like linking a specific practice to a gender, and this leaves out other non-binary possibilities. And when I'm at the doctor's appointment, they tell me that if I'm not trans, I won't have the mastectomy. And I was very confident of my opinion, and they told me, okay, please remove your clothes. And clothes off. And with the doctor very close to me, that professional actually would touch my breasts when I was naked. All of this, in a way, goes against my identity. Or when people assume me as masculine, automatically, there might be a difficulty regarding my pronouns. And there is this medical appointment. We should be talking about my body and my health, but we spent 15 minutes talking about my pronouns and how it's difficult for the doctor to accept my pronouns. I'm 38 years old, and I basically don't see any doctors. But unfortunately, even going to get my COVID shot made me anxious because I had to expose myself to the medical health system. From the Assembly, we understand that comprehensive health also includes care as a community. We organize ourselves in order to guarantee access to all the rights, but we also do so when it comes to an emergency situation. For instance, when a colleague is in an extremely vulnerable situation, which happens a lot. And as an assembly, we systematize these lessons learned. We call this el apañe, as in we are all together and we help each other. So we share everything, and we live together in a space where the state is not present, where families are not present. We actually learn from community experiences organically as well when it comes to having access to comprehensive health. This year specifically, we worked with mental health. We articulated our activities with the state in its different institutions, for instance, in a public hospital, or through specific programs such as the TTNB program. This is the right strengthening program as sponsored by the Ministry of Women, Genders and Diversity. And we also have community health spaces in order to show our friends their rights, and also to build a framework so that we ourselves can provide collective support, but with the specific tools that our experiences might not have provided us with.
Okay, we don't have time for the Q&A section, so I will have to close the room because we have the next panel. We'll start in 10 minutes. Oh no, we have the like.
Sorry, I believe we're going into lunch.
Yeah, I forgot about that because of the time schedule. Sorry, we have to cut the panel off, and then we have a lunch, and an hour later we start again. Thank you.